All right. Good day, everyone. So today we'll talk about the third section, section C. Okay, so welcome to section C. Here we will focus on dissociative and somatic disorders. And this is one of the more misunderstood parts of abnormal psychology because the suffering here often shows up in ways that people do not immediately recognize as mental health related. So when many people imagine mental illness, they picture obvious sadness, panic, or bizarre behavior. But here, distress may show up as disconnection from memory, identity, consciousness, or perception, or sometimes as intense distress centered on the body and health concerns. So these disorders challenge the stereotype that psychological distress always look emotionally dramatic on the outside. So that is the big idea for this section. Sometimes the mind expresses distress through fragmentation and sometimes through physical preoccupation. Different presentation, same reality, the suffering is still real. And that brings us to the question, what exactly connects these two clusters? Okay? So this slide gives us the bridge between the two clusters. Dissociative disorders involve disruptions in the normal integration of consciousness, memory, identity, emotion, perception, and behavior. In other words, parts of experience that are normally connected stop feeling connected. Somatic disorders, on the other hand, involve physical symptoms or health concerns, accompanied by excessive distress, anxiety, or preoccupation. Here, the issue is not disconnection from identity or awareness, but a pattern of being consumed by bodily symptoms or illness fears. What connects them is this. In both cases, the person's suffering is real, but the presentation is often understood. So one person may look fine while quietly feeling unreal and disconnected. Another may seem overly focused on bodily symptoms and get dismissed as dramatic. In both cases, the easy interpretation is often the wrong one. So now let us take the first cluster on its own and understand what dissociation really means. So let's try to understand, okay, dissociative disorders. First, dissociation refers to a disruption or discontinuity in the normal integration of core psychological functions. That phrase sounds technical, I know, so let's make it simpler. Experiences that are normally woven together, memory, awareness, identity, body experience, emotion, perception, they start to feel split, detached, or out of sync. The slide organizes this into three broad areas. First, cognition, including memory and awareness. Second, the self, including identity and body experience. And third, the external world, including perception and emotion. Now, mild dissociation can happen in everyday life. For example, you may drive somewhere and realize you barely remember the trip because your mind was elsewhere. That does not mean disorder. Clinical significance appears when the disruptions become severely distressing, all right, or persistent. In other words, when it is not just zoning out but something that interferes with life. So the next question is, what does dissociation actually look like when it shows up with real people? And that is what we will talk about, all right, and on how dissociation can look like. Dissociation can show up as a spectrum of internal disconnections, all right? And the slide breaks it down into four useful categories. First, the self. The person may feel detached from themselves or from their identity. Second, reality. The world may feel unreal, dreamlike, distant, or strange. Third, memory. Important parts of experience may feel missing, and fourth, internal experience. The person may feel cut off from thoughts or emotions. One reason this topic is hard for students at first is that dissociation is not always dramatic. Sometimes, and most often, it is subtle. A student may say, I know I was there, but it feels like I wasn't really there. Or everything felt foggy, like I was in a dream. Or I know I should feel something, but I feel disconnected from it. Sometimes there's deja vu, right? So that is why the quote on this slide matters. These experiences can be deeply distressing and disruptive even when they look subtle from the outside. And two of the best known examples of that subtle but disturbing experience are depersonalization and derealization. Now, here we distinguish two related but different experiences. Depersonalization means feeling detached from oneself, almost as if you are watching yourself from the outside. So a person may say, I feel like I am observing my own body, or it is like I am here but not fully in myself. Derealization means feeling detached from the surroundings. The world may seem unreal, foggy, flat, distant, or dreamlike. So a student might describe it as everything looked normal but it did not feel real, or I knew I was in class but it felt like I was inside a movie scene. The frightening part is that the person often still knows that reality has not literally changed, so they are not necessarily psychotic. They know something feels off, and that makes the experience even more unsettling. It is like your mind saying, I know this is real, but why does it not feel real? That gives us an important transition because dissociation is not only about feeling detached. Sometimes it also involves missing parts of memory. So now, dissociative amnesia. Dissociative amnesia involves an inability to recall important autobiographical information. Okay? And this is usually related to traumatic or stressful experiences. And the memory loss is too extensive to be explained by ordinary forgetting. The last part matters. Okay? This is not, I forgot where I left my charger or my car keys, or I cannot remember what I studied because I did not actually study. This is more significant than normal absent-mindedness. The missing memory usually concerns highly stressful or traumatic events. The slide also notes that the scope can vary. The person may be unable to remember a specific event, only parts of an event, or a broader stretch of autobiographical information. In other words, the gap can be localized, selective, or more extensive. So the key idea here is that memory loss can become part of the psyche's way of dealing with overwhelming experience. And when we move from memory gaps to disruption in identity itself, we arrive at one of the most misunderstood disorders in this section. Dissociative Identity Disorder, or DID. It involves a disruption in identity and agency. The slide highlights two core elements: distinct personality states, or marked continuity in the sense of self, and memory gaps that affect everyday events or traumatic experiences. Rest. This is where we need to be especially careful because DID is one of the most sensationalized disorders in popular media. People sometimes reduce it to having multiple personalities. It used to be multiple personality disorder, and they reduce it to having multiple personalities in a dramatic movie style way, but clinically it is more complex and more painful than that. And the most important point on this slide is the phrase clinical reality. DID is not the same as being moody, inconsistent, or having different sides. Everyone has different roles and moods. That is normal. DID, however, involves a much deeper discontinuity in the sense of self, often with recurrent amnesia and a trauma-linked background. Because DID is so often misunderstood, the next slide is very important: clinical cautions. Now, this slide is the slow down and think carefully slide. Dissociation is often associated with trauma, especially when trauma is severe or chronic. But not all dissociation means DID. That is why differential diagnosis matters, because dissociative presentations can overlap with psychosis and substance effects, neurological and medical conditions, and culturally shaped experiences. For example, hearing voices in a psychotic disorder is not the same thing as identity disruption with dissociative amnesia. A seizure-related condition is not the same as a dissociative episode, and some culturally meaningful altered states should not be rushed into pathology. So the key point here is clinical humility. Again, clinical humility. Just because a presentation looks unusual, it does not mean we should jump to the most dramatic label in the room. Again, psychology is not a contest for most interesting diagnosis. And with that caution in mind, we now shift from dissociation to the other half of this section: somatic symptom and related disorders. Now, these disorders involve physical symptoms, bodily concerns, or illness fears, and often accompanied by excessive psychological responses. The problem is not simply that the person has a symptom. The problem is the level of distress, anxiety, preoccupation, and disruption surrounding the symptom. This slide that you see emphasizes three important ideas. First, there is distress and anxiety, often disproportionate worry about health. Second, there is behavioral impact. These concerns interfere with daily life. And third, the symptoms are not fake or feigned. The last point is especially important because this whole cluster is often misunderstood. People hear somatic and immediately think, so it's all in their head. That is not the right interpretation. The experience is real, the suffering is real, the issue is the pattern of excessive and impairing response. Now, let's go into the first major condition in this cluster, the somatic symptom disorder. Somatic symptom disorder is characterized by distressing physical symptoms paired with excessive thoughts, feelings, or behaviors related to those symptoms. So this slide highlights three key features. First, health anxiety, intense worry and distress about the symptoms. Second, a behavioral pattern, frequent body checking, reassurance seeking, repeated appointments to the doctor, diba? Constant monitoring by use of different gadgets, could be blood pressure, alright, or oxygen monitoring. Third, the fact that the symptoms may be medically explained or unexplained. And the last point is crucial because the diagnosis does not depend on proving that the symptom has no medical basis. A person can have a real medical issue and still have an excessive, impairing psychological response to it. So the defining feature is not whether the symptom is real. The defining feature is the excessive and impairing response pattern. And if the main issue is not the symptom itself, but the fear of having or developing serious illness, then we are talking about a closely related but different diagnosis. And that is illness anxiety disorder that involves a strong preoccupation with having or developing a serious illness. Even when somatic symptoms are minimal or absent, that is one of the clearest distinctions from somatic symptom disorder. In somatic symptom disorder, there are distressing bodily symptoms at the center. In illness anxiety disorder, the main problem is the fear of illness itself. The person may repeatedly check their body, Google symptoms, right? Seek reassurance, request lab tests, or sometimes do the opposite and avoid doctors because they're afraid of what they might hear or find out. So this slide captures that nicely under care behaviors. A relatable example is the student who feels one unexplained sensation, say perhaps a chest flutter or a mild headache, and within 15 minutes is convinced it must be a serious disease. And then WebMD becomes their co-diagnostician, which is almost never helpful. So the key idea is this: the preoccupation stays high even when reassurance is given. And from there, we move into a condition where symptoms can look neurological. Functional neurological symptom disorder, or also called conversion disorder, involves symptoms affecting voluntary motor or sensory functioning. The slide lists examples such as weakness, paralysis, seizures, or sensory loss. And the most important teaching point here is authenticity. The symptoms are real and distressing, not intentionally produced. That means the clinician should not dismiss them as faking just because standard neurological explanations are not straightforward. This is why the slide's quote is so important. These symptoms must be understood clinically rather than dismissed as simple faking. That kind of dismissal can be incredibly damaging. So if the symptoms are not intentionally produced here, what about cases where symptom production is intentional? That takes us to one of the most important distinction slides in the whole section. Here. This slide is clinically important because it separates three things that people often confuse. First, somatic disorders. The symptoms are not intentionally produced. The distress is genuine even if the presentation is psychologically shaped. Second, factitious disorder. Symptoms are intentionally produced or falsified in order to assume the sick role. The motivation is internal, being seen as ill, receiving care, taking on the identity of a patient. And third, malingering. Symptoms are intentionally produced for external gain, such as avoiding work, avoiding duty, getting compensation, or some practical benefit. This is exactly why diagnosis in this area must never be careless. Accusing someone of faking when they are not can do real harm. On the other hand, failing to distinguish these patterns can also create confusion. So this is one of those moments where clinical judgment matters more than dramatic assumptions. Why these disorders are often misunderstood. This slide really gets to the stigma issue. Dissociative and somatic symptom disorders are often dismissed as exaggeration, attention-seeking, faking, or just stress. Why? Because they often do not fit what people think a real disorder should look like. If someone is not visibly psychotic or clearly depressed, people may minimize what they do not understand. But this slide pushes back on that in two ways. First, real suffering. These disorders involve genuine distress and require nuanced empathetic assessment. Second, the mind-body link is complex. Distress can appear in many physical and psychological forms. In other words, the absence of a clear physical explanation does not mean the suffering is fake. That is a very important clinical and ethical point. And once we understand that, we are ready to talk about why diagnosis in Section C is often so complex. Section C is diagnostically complex because the symptoms can overlap with several domains at once. The slide breaks this into three areas. First, clinical overlaps. Trauma-related disorders, psychotic disorders, and anxiety disorders can all resemble parts of these presentations. Second, physical factors. Neurological conditions, medical illness, and substance effects must be ruled out or carefully considered. Third, cultural context. Some experiences are shaped by cultural meaning and should not be interpreted narrowly. This is why pattern recognition and clinical judgment matter so much here. If you only look at one symptom in isolation, you can go very wrong very quickly. This is one of those areas in psychopathology where interesting is not enough. You need to be accurate. And that brings us to the recap where we pull the whole section together. This recap slide brings the section into one clean contrast. On one side, dissociative disorders, which involve disruptions in the integration of memory, identity, awareness, perception, or consciousness. The central issue is fragmentation or disconnection in how experience is held together. On the other side, somatic symptom disorders involve physical symptoms or illness fears, accompanied by excessive distress, anxiety, or preoccupation. The central issue is not fragmentation of self, but the way distress becomes organized around the body and health concerns. The unifying point is the quote at the bottom. In both clusters, the suffering is real and deserves careful, compassionate, and non-dismissive clinical understanding. And that recap sets up our final move because the next section takes us into a very different kind of disturbance. Right? But before that, this slide shows the key sources. Okay, grounding this section in DSM-5 and DSM-5-TR. Alright, and major abnormal psychology text by Barlow, Duran and Hoffman, Comer and Comer, Kring and Johnson, right? These sources matter because disorders like the ones in section C are easy to oversimplify, so we need both diagnostic rigor and clinical sensitivity. That quote at the bottom says it well: scientific rigor and clinical empathy belong together. If you have empathy without rigor, you may misunderstand. If you have rigor without empathy, you may become cold, dismissive, and clinically unsafe. And with that foundation in place, you're ready to move into the next section. Okay. In section C, we focused on disconnection and bodily preoccupation, the ways distress can show up as fragmentation in experience or in turns concerned with physical symptoms and health. Now, in section D, the clinical focus shifts toward psychosis, delusions, hallucinations, disorganized thinking, and impaired reality testing. That is a different kind of disturbance. We are moving from altered integration of experience to more direct disturbances in how reality itself is perceived and interpreted. So the next question is no longer only what happens when the self feels disconnected. It becomes what happens when a person's grasp of reality becomes fundamentally disrupted. And that is where we go next. I will upload the next lecture. Okay, just please stand by. Again, thank you so much for listening. Until next time.